Next speaker, Yazan Eldewary, managing pre-procedural hyperglycemia in vascular surgery.
Thank you again for the honor of being here and participating in this conference. Early in my career, I responded to an email from an endocrinology fellow who was interested in studying perioperative hyperglycemia, and I said that maybe I'll get involved in this quick research project and come up with answers. And the more I got to study this subject, I realized it's extremely difficult to come up with answers for hyperglycemia management in vascular surgery. I do not have any relevant disclosures to this talk. Diabetes, as you all know, is a syndrome of metabolic dysregulation. It manifests itself as elevated systemic glucose, but is also associated with many pathologic states. Vascular manifestations of diabetes, as were mentioned already, result in early development of peripheral arterial disease, a more diffuse picture of involvement, as well as renal dysfunction that exacerbates the effects of peripheral arterial disease. But the topic of this talk is really the perioperative hyperglycemia, is how glucose elevation can influence outcomes after vascular surgery and how this can be improved. Perioperative hyperglycemia results from a catabolic state that results from the stress of surgery, but it is further exacerbated by the insulin resistance in some patients. So that is why not all patients develop perioperative hyperglycemia. Not all patients who have insulin resistance develop it either. So there has to be a combination between surgical stress and insulin resistance. Now, hyperglycemia in critically ill patients was really started to be looked at over the last 3 decades, but 20 years ago, Vanderberg popularized the idea of looking at better control of hyperglycemia in critically ill patients in the medical ICU and surgical ICU, and recommended as a result of his studies that a tight glucose control with levels between 90 to 110 should be followed in order to improve outcomes. Now, this, of course, is extremely difficult to follow, and therefore most of the society guidelines call for a little more liberal glucose measurements, but trying to keep it somewhere below 180 or below 200 for perioperative risk reduction. Now, what we know is that poor glycemic control or high glucose levels is associated with poor outcomes. What we don't know is how to deal with this problem. So this is a study that we did early on, looking at a large number of patients in my institution who underwent open vascular surgery, and we chose the level of hyperglycemia to be 180 milligrams per deciliters, and found that with multivariate regression analysis to be associated with almost every poor outcome you can imagine: mortality, renal outcomes, wound outcomes, reoperations, and readmissions. Interestingly, patients who did have a diagnosis of diabetes preoperatively had a somewhat protective effect of hyperglycemia compared to patients who did not have diabetes as a preoperative diagnosis. Now back to talking about what we can do about it. Now this has been evaluated. Some people looked at looking at aggressive insulin infusion protocols to address this. And in this prospective randomized trial, this was found to decrease cardiac complications. Now, there were many other randomized studies that looked at how to manage perioperative hyperglycemia with the infusion protocols, and the results were variable as shown in this systematic analysis. Now, another method to control it is with a long-acting insulin, and this was studied at my institution in Emory by the endocrinologists I collaborated with, who found that you can decrease some of the poor effects of hyperglycemia with basal insulin supplementation better than sliding scale insulin supplementation. Another modality is to look at sitagliptin, which is an incretin-based hormone, exogenous hormone that can be administered to allow an increase in endogenous insulin production as a result of hyperglycemia in a dose-dependent fashion. Now, looking at this still has not really been evaluated in improving outcomes in vascular surgery, but it was shown to decrease the amount of insulin and fluctuation in glucose level in the perioperative period. More, of course, is to be known about this in the future. Intraoperative management of hyperglycemia, the current recommendations are extrapolated from cardiac surgery, and these call for in patients who are undergoing open complex vascular surgical operations, such as a long lower extremity bypass operation, open aneurysm repairs. Those patients do require hourly monitoring with intravenous insulin therapy with a goal glucose level between 100 to 180. So that was all about the perioperative measurements of glucose, but the more important thing is hemoglobin A1C, which reflects average serum glucose concentrations in the 3 months prior to measurements. So it's an important biomarker in calculating the cardiovascular risks and the overall risks after vascular surgery. Now, it is agreed upon that all patients who have vascular arterial operations should undergo a baseline A1C measurement before surgery, largely because if the patient turns out to be diabetic, he or she will benefit from level optimizations, and if they are non-diabetic, they would benefit from a screening test that would allow us to treat this appropriately. Now, hemoglobin A1C optimization can allow us to improve the long-term and the short-term outcomes of vascular surgery. In this study, this showed an improvement in reoperation and readmissions. This is a study that we did in a retrospective fashion at our institution in patients undergoing lower extremity revascularization, and looked at the outcomes, the long-term outcomes of that for limb salvage as it related to hemoglobin A1C in the preoperative period. We found that there is a significant influence of A1C elevation on the long-term outcome of limb salvage, and not only that, we found that that effect is dose dependent. That is, the higher the A1C is, the higher the likelihood of limb loss in the future. In conclusion, screening for diabetes by A1C measurement ahead of any elective vascular intervention will provide an opportunity to improve perioperative outcomes and long-term outcomes. Intensive insulin treatment is recommended intraoperatively and postoperatively to decrease postoperative events, as we know now. Again, the verdict is not clear until now on how this glucose management should be undergone. And more importantly is that this is a very rich field for research and an important field to be looked at by anybody in the audience who's looking at expanding their academic career, because perioperative glycemic management is a research priority with no clear vascular specific guidelines. Thank you very much.